Welcome everyone. Today we'll be going over the management of COPD exacerbation based on the GOLD 2024 recommendations. Acute exacerbation of COPD is going to be defined as an acute worsening of respiratory symptoms. So primarily it's going to be increased shortness of breath, cough, and sputum production. And these symptoms are going to be going beyond the normal day-to-day variation of the patient's COPD. Now, it's important to be vigilant for signs of upper respiratory infections because most acute exacerbations of COPD cases are going to be triggered by respiratory infections, either viral or bacterial. Also be vigilant about CHF because CHF can also mimic or worsen COPD exacerbations. Now, COPD at baseline is going to be a prothrombotic state, and it's going to be especially worse during exacerbations because there's going to be inflammation, immobility, and hypoxia, and so that is going to increase the prothrombotic state. And so there was a study that was done, and the study showed that there's around 25% of severe acute exacerbations of COPD without a clear infectious cause are due to pulmonary embolism. So this is going to be essential to consider in unexplained cases. Also look at the patient's previous exacerbations or their history of steroid use or intubation because it can predict severity and prognosis. Now, patients who experience frequent exacerbations are going to be at a higher risk of poor outcomes. If they have been intubated in the past, then that can suggest more severe disease and it can prompt us to earlier aggressive treatment or earlier ICU consideration. So when we evaluate patients with a acute COPD exacerbation, the initial workup is going to help us identify the cause and the severity of the disease. And so what we want to do is we want to start with a chest x-ray to look for pneumonia, pneumothorax, or signs of heart failure. And we also want to do a blood gas, either arterial or venous, and that is to assess how severe the exacerbation is. And we can do that by looking at the CO2 retention and the acidosis. And this can help us guide our decision about admitting the patient to the ICU or giving them a non-invasive ventilation. ECG and troponin are also important because MI can mimic or trigger COPD exacerbations, and arrhythmias are also going to be common in these patients. And BNP can help identify heart failure, so if it's increased, then we can say that the patient more likely is to have heart failure, and heart failure can also present similarly to an exacerbation, especially in elderly patients. Viral testing is going to be important for flu and COVID. Respiratory viruses are going to be major triggers of COPD, so it is important to do viral testing for flu and COVID. And finally, consider a PE workup like a D-dimer or a CTA, CT pulmonary angiogram, especially when there's no obvious infection and signs like leg swelling or disproportionate hypoxia being present. Pulmonary embolism, again, is going to account for up to 25% of severe unexplained exacerbations, so it is a huge number. Now let's move on to the management, starting with oxygenation. The number that we want to oxygenate the patients to is going to be a target SpO2 of 88 to 92%. And the reason why we want this range is to avoid complications of too much oxygen. So if we administer oxygen too aggressively, it may decrease the respiratory drive because some of the patients might be reliant on hypoxic drive because they're reliant on the CO2 being present. And so with hypoxia, there's going to be a drive to breathe. And so if we give too much oxygen aggressively, then that can decrease their respiratory drive. And so this recommendation is actually supported by observational data indicating that there is increased mortality with over oxygenation. And this was by the British Medical Journal. Now let's move on to the bronchodilators. This is going to be the cornerstone treatment for acute symptom relief. And so we're going to be using short-acting bronchodilators such as albuterol, which is a beta agonist, and ipratropium, which is a anticholinergic. And these medications are going to work together to reduce bronchospasm and improve airflow. The combination of ipratropium and albuterol in a single nebulized formulation is called duonebs. And when patients present with COPD exacerbation initially, we stack nebulized treatments. So we administer duonebs 3 times within 1 hour, usually 20 minutes spread out for each administration, and that would give patients rapid bronchodilation, thereby relieving their symptoms. Once the patient is more stable, we're going to be switching duonebs. We're going to switch giving duonebs every 4 hours regularly, and we're going to let the patients use extra albuterol every 2 hours as needed. And as patients get better, we're going to try to use the inhalers less often, and we're going to try to work them back toward their normal maintenance medications. Now, it's important to note that these agents do not alter the course of the disease, but they are going to be essential for symptom control. Now let's talk about steroids. Systemic steroids are proven to reduce the duration of exacerbation, rate of treatment failure, and time to next exacerbation. The reduced trial showed that 5 days of prednisone, 40 milligrams daily, was non-inferior to 14 days. And so that thus minimizes the steroid-associated side effects like hyperglycemia, infection risk, and myopathy if we were to do 5 days instead of 14 days, because the reduced trial showed that 5 days of prednisone, 40 milligrams daily, was non-inferior to 14 days. So that would minimize the side effects from steroids. The CHEST 2007 and Cochrane reviews have supported the efficacy of steroids across routes, like oral is equivalent to IV, unless the patient cannot tolerate oral meds. In severe cases, IV methylprednisolone or nebulized budesonide may be considered. Now let's discuss non-invasive positive pressure ventilation. So this is going to be indicated in patients with respiratory acidosis. If patients have a pH of less than 7.35 or a PaCO2 greater than 45, then we can consider them for non-invasive positive pressure ventilation. So if patients have respiratory acidosis, severe shortness of breath, or persistent hypoxemia despite oxygen, then that will be an indication for non-invasive positive pressure ventilation. Now, the important thing about non-invasive positive pressure ventilation is that it reduces the need for intubation, length of hospital stay, and mortality, according to Cochrane 2004. And it also improves ventilation by resting the respiratory muscles, and it reduces the work of breathing, and it also improves alveolar ventilation. Now, if non-invasive positive pressure ventilation fails or is contraindicated, so if the patient has altered mental status or if they're vomiting and not able to secure their airway, then the patient should be intubated and admitted to the ICU. Now let's discuss antibiotics, which is a controversial topic in acute exacerbation of COPD because it is difficult to identify who will benefit. Now, the antinosing criteria state that patients with all 3 cardinal symptoms, so the cardinal symptoms being shortness of breath, increased sputum volume, and sputum purulence, so either with all 3 cardinal symptoms or at least 2, including purulence, are going to be more likely to benefit. Now, for those requiring mechanical ventilation, antibiotics are going to be routinely indicated. CRP and procalcitonin may help guide antibiotic stewardship. Now, CRP has shown promise. The New England Journal of Medicine study showed that the CRP thresholds can safely reduce unnecessary antibiotic use. And so this trial protocol provided doctors with guidance that a CRP level less than 20 tells us that antibiotics are unlikely to be beneficial to the patient, and therefore we don't really need it. And the CRP levels between 20 to 40, antibiotics may be considered if there's purulent sputum. And for levels above 40, antibiotics are going to be likely to be beneficial. Now, Procalcitonin is more specific for bacterial infections than CRP. It rises in response to bacterial endotoxins, but it's going to remain low in viral infections and non-infectious inflammation. Now, initially, Procalc was promoted to guide antibiotic duration and initiation in various infections like pneumonia, sepsis. However, there's this cautionary tale in the ICU setting. Now, a 2017 European Respiratory Review article noted that Procalc-guided therapy in ICU patients with acute exacerbations of COPD may paradoxically increase mortality. Now, the reason why there is this paradoxical increase in mortality is that Procalc may remain low in early bacterial infections or in immunocompromised patients. And so that will lead to a delay in antibiotics or doctors withholding antibiotics from patients. And so that would lead to worsened outcomes. Now let's discuss antibiotic choice. The antibiotic choice for COPD exacerbation patients is going to depend on their risk factors for Pseudomonas. And the risk factors for Pseudomonas are frequent exacerbations, recent hospitalization, or prior Pseudomonas cultures. Now you can use the HHP rule to assess for Pseudomonas risk. So the H is for hospitalization, the other H is for history of Pseudomonas, and the P is for prior frequent exacerbations or antibiotics. Now, if the patient does not have any Pseudomonas risk factors, we can give them amoxicillin clavulanate or Augmentin. We can give them doxycycline, or we can give them azithromycin or TMP-SMX, also known as Bactrim. If the patient has Pseudomonas risk factors, we can give them fluoroquinolones like levofloxacin, cefepime, or piperacillin tazobactam. Now, the duration for the antibiotics is typically 5 to 7 days for inpatients and 3 to 5 days for outpatients, depending on the agent and the severity. Now, a mnemonic that you can use to remember the antibiotics is with patients with no Pseudomonas risk factors, you can use the mnemonic ADA therapy. So the A is going to be for amoxicillin clavulanate, the D is for doxycycline, and the A is for azithromycin, and the T for TMP-SMX. So give ADA therapy when Pseudomonas is absent. So the A starts with absent. Now, when the Pseudomonas risk factors are present, we can use the mnemonic FCP for Pseudomonas. So the FC kind of sounds like a factor, so Pseudomonas is a factor in this patient population. The F is for fluoroquinolones, the C is for cefepime, and the P is for piperacillin tazobactam. Now let's discuss antivirals and VTE prophylaxis. Now, antiviral therapy with oseltamivir should be initiated if influenza is suspected or confirmed, even if symptoms started more than 48 to 72 hours prior. VTE prophylaxis is essential during exacerbations, as patients are going to be immobile, they're going to be experiencing systemic inflammation, and they have potential endothelial injury, and these all contribute to a hypercoagulable state. So that is it for the video. Hopefully this topic was helpful, and this management video was from the MGH, Massachusetts General Hospital, Harvard's hospital, and they have a workbook, this textbook called MGH Household Manual, and all of this information has come from that manual if you want to reference the information on your own.